So we're going to start with rheumatoid arthritis. There's so much to learn that it has 2 sheets.
Yay.
So let us begin. Before looking at your papers, what do you know about all autoimmune disorders?
Young women.
It happens to young women.
There's a genetic component.
Genetic component plus a trigger that turns it on, and that is called
The
Gene activation.
gene.
flip.
I don't know why I was doing it like so aggressively. Okay. It's not on your paper, so
Gene expression.
that is not true.
Gene like translation.
That is not true either. If you're starting something, what is that word that we would
Gene
use?
initiation.
Oh, that was so close.
Yeah.
If I'm going to begin labor on a woman who is
Induction.
pregnant. Oh, okay.
Yeah.
Gene induction. Okay. So you have a genetic component, meaning that gene is just sitting there and it's dormant, and it could stay dormant for how long?
Like
Your whole life, right? You could have the genetic component for it, right? But it just sits there dormant. Then there's going to be a trigger. What are the most common triggers that we see in autoimmune disorders?
Viruses?
Viruses,
Smoking?
major trauma, not really smoking. It's got to be something big.
Like environmental stuff.
Like what?
Like
Allergies.
No, y'all, this is a big trigger, not like, oh, there's pollen in the air, like
Fire? Smoke?
a big trigger.
Okay.
Like
Wow.
you had like a massive virus, like you got a bunch of vaccines at one time. Sometimes it's just one. Because vaccines cause a big immune response, right? And so it can cause gene induction in some people. Okay, massive stress, like something really bad happened to you and you went through a very stressful period of time. So these are big things that happen that then through gene induction turn on the gene. Now, every autoimmune disorder, once your gene is turned on, likes to attack in different places, right? Like RA, the main place it likes to attack is
The
joints. But remember, all these autoimmune disorders are going to attack the entire body. So you're going to learn all the signs and symptoms, but they do have ones that they prefer. So RA likes the joints. Lupus likes the kidneys and skin. Okay. Let's see. Multiple sclerosis likes the
the
Neurons.
CNS. It's fine.
I need
Nerves.
doesn't attack the nerves. It attacks the
Brain.
what part of the brain does multiple sclerosis attack?
Hypothalamus?
No, I know.
I know, like
Didn't we already do neuro?
Yeah.
Okay.
I'm just dumb.
Okay, well,
it affects the myelin sheath.
that's it, ma'am. All right, then. So the myelin sheath, okay. So you see each autoimmune disorder will attack different places. You understand that? It can't differentiate self versus non-self anymore. In our immune system, we have an innate immune system that can constantly see, this is my body, don't attack it. This is not my body, attack it. You lose the ability to do that. And then each autoimmune disorder has a certain place they specifically like to attack, but it attacks the entire body, which is why you'll see systemic signs and symptoms for every one of these that we're covering today. Okay. Okay. Now you can look at your papers if you want, but try not to. All right. So we know that rheumatoid arthritis is, and anytime you see rheumatoid, that means a systemic inflammation response. Y'all know that if you go see a rheumatologist, you're looking for some kind of inflammatory response, right? And then arthritis, arth means joint, itis.
Inflammation.
That is correct. All right. So this is a inflammation of connective tissue, and it causes systemic inflammation. So we had a genetic component, then we had a trigger. All right, so that's going to increase your IgG. What's an IgG?
Immunoglobulin.
Immunoglobulin G, okay, which those are the ones that help with autoantibodies. What's an autoantibody?
It's an antibody that is
What does
for
auto
your
mean?
own self.
Right, it's going to attack self, yes. And the autoantibodies are what we call the rheumatoid factor, which is why in RA, we draw an RF. If the RF is positive, 100%, we diagnose with rheumatoid arthritis. Are we clear so far? Okay. Once your body sees and is like, oh, I have a bunch of enemies here, even though it doesn't know it's itself, right? Then it's going to form antigen antibody complexes. What's the antigen in this case?
The joint.
You, yeah, just you, right? And then the antibody is what your body is creating against that antigen, which is actually you, okay? What type of immunity does antigen and antibody complexes?
Adaptive.
Yes, but more specifically, what type of immune response is this? No, that's T cells. I know.
So humoral.
I love it when you say you right though, huh?
So humoral.
Humoral, which is what type of cells?
B cells.
B cells. This is a B cell immunity issue. Okay. all of those antigen antibody complexes, which are now like attacking your own cells, are now going to go and deposit in the synovial membranes. What is a synovial membrane?
It's the membrane, it's like the space that surrounds the joint.
Space that surrounds a joint. And your articular cartilage. What is the job of cartilage?
It's like for movement.
Movement, and also somewhat to cushion, to make structure, right? And so when those go and deposit into your joints say, oh, something is wrong, which dilates and leads to increased capillary permeability, which then causes swelling in the joints. I was so mad at y'all last night. I cannot even
That was
tell you.
me. I'm
Okay.
tired.
Oh my God. All right. So anyhow, so then your body, as those antigen antibody complexes deposit in the joints, that's a new response, a new inflammatory response. So your body says like, oh my God, I don't like this. And what's the first thing it sends out anytime it doesn't like something?
Histamine.
No, first thing your body sends out
Neutrophils.
neutrophils, and they attack everything non-discriminately, right? Mostly they're used in bacterial, but they'll shoot anything, right? Anything that comes up, right? So the neutrophils are going to come out and they release something called proteolytic enzymes. Okay, proteolytic enzymes. To lyse means
To
kill.
Kill.
So it kills your proteins. Okay, that's bad, and that's going to eventually destroy the joints. Okay, then after that B cell response, the only crossover from cell-mediated response is which cells? Which ones help the B cell side?
Helper T cells.
Helper T cells. So helper T cells are going to come in. When helper T cells come in, they tell your body again, this is like the third time, something is wrong, and bring more inflammatory mediators like monocytes. What do monocytes do?
Release his, no. That's
They like travel through the blood and then.
Well, yes, they
goes
travel through the blood.
And then it like it brings other cells, right?
No, it does one job. Monocytes have one job, like neutrophils kill bacteria, right? Which ones kill allergies?
Oh, eosinophils.
Eosinophils. So what do monocytes do?
release histamine?
No.
No. It's the mast cells.
Yeah. Glad you're staying for the next session. Doo-dah, doo-dah. All right. Monocytes come out in chronic inflammation. That's their job, is chronic inflammation. And RA is a chronic inflammation. Helper T cells also bring out macrophages. What's the job of macrophages?
They eat
They eat what?
the
The bad
Dead
cells.
bacteria.
Well, they eat everything,
everything.
but it doesn't even have to be dead,
Come on.
right? Yeah. And so since all these antigen antibody complexes in your cells are in the way, it's just going to start eating your own body. What is cytokine's job?
They cause a massive immune response.
Yes, they sound the alarm. So now for the fourth time we have,
Something's wrong.
that's why this is such a massive inflammatory response all over your body. What is TNF?
Tumor
Tumor
necrosis.
Tumor
Factor.
necrosis factor. And what's its job?
To stop like mutations, like to correct
Of
them.
cells. Yes, to stop mutations of cells and correct them. Not only cancer cells, but all kinds of cells, right? And they have a massive help in the immune response to, it's a part of the T cell system, right? And it's going to help you to get into the cells that are being attacked, right? So this is all a huge inflammatory response. Do y'all see that?
Yes.
Okay. So, and then I gave you just kind of like a little cheat sheet over here of how RA is going to progress. Okay. So what happens is we have this huge swelling and all of this stuff, right? Right.
Yeah, right.
Okay. So the joints are now all swollen and angry and red and inflamed. Why are they all red?
Because of the vasodilation.
Because of the vasodilation. Why are they swollen?
Vasodilation.
Vasodilation and capillary permeability, third space fluid. Now we've got chronic inflammation. Okay. So now the synovial membranes are going to get hypertrophied. What does hypertrophy mean?
Like overworked.
Big and large, big cells full of fluid. Okay. That hypertrophied, those cells that are now big start to grow into your cartilage, your ligaments, and your tendons. That is bad. And that forms something called pannus. I hate that word. But what does it mean?
Is it like a scar tissue almost?
It's like
thick tissue?
it's not scar tissue. It's very vascular. It's red vascular tissue. It's meant to be healing tissue, but because there's so much damage, it's forming and forming and forming and forming and forming, and it's replacing all of your normal tissue. Okay, so this is a really big deal. That is the grossest word on the planet. I don't care who says, is it a penis? Is it an anus? Which one is it? Make up your mind, and it's weird. Okay.
Let's mix the two to-
Exactly. That sounds great. Let's mix the two. All right. So when the pannus forms, it's so rapidly growing because it's so vascular that it's going to end up destroying the cartilage in the bone, which end result of RA is joint destruction. So what's our number one goal in RA patients? Prevent joint destruction. Do we understand?
Yes.
And how do we prevent joint destruction?
Medication.
Yeah, medication. Okay. There are obviously other ways, but that's what you will learn today is medication. Now, all autoimmune disorders go like this pattern. What does this pattern mean? Exacerbations where they have horrible symptoms and then they go into remission where they have no symptoms, right?
Right.
Okay. But every exacerbation, what's happening?
It's just like a flare up.
Like
Okay.
it's progressively getting worse.
Yes, it's ruining your joints every single time you get a flare up. What is the number one, like the first thing that we do to treat RA?
Oh, methotrexate.
Yes, but we usually don't start with
We start
methotrexate.
with NSAIDs.
NSAIDs daily. So we start with NSAIDs. We'll cover this more later. You don't have to write it down. Okay. I'm just making sure that we're doing an overview. Okay. So we do NSAIDs daily to help keep these inflammatory responses down. Right. And then what happens during exacerbations? Because obviously the NSAIDs weren't enough. You still flared. And this is true for all autoimmune disorders. We do the same pattern.
Once you start getting more exacerbations, we increase in the amount of medication we give.
We need to give something else during an
Right,
exacerbation.
methotrexate.
No.
The corticosteroid.
Corticosteroids. We
Yeah.
give corticosteroids during exacerbations because we don't want to use corticosteroids long term because they have like 14 side effects, right? I should have learned all those. Okay. So we give corticosteroids during exacerbations. And what happens if they're having lots of exacerbations? Now, what do I have to do to my immune system?
Decrease it.
Right. So we're going to tell it to shh. And how do we tell it to shh?
Methotrexate.
No.
DMARDs.
Eventually,
DMARDs is a
right.
joke drug class. It's not really a drug class.
Like immunosuppressants.
Immunosuppressants. Okay. Now, is methotrexate somewhat considered an immunosuppressant? Yes, but we can also give azathioprine or cyclosporin or any of those other immunosuppressants we've already covered, right? Okay. So if you are going to give an immunosuppressant, yes, methotrexate is the drug of choice. Yes. Okay. All right. Y'all know what happens to young women, which is usually in their 30s or 40s. Now, smoking is a risk factor for RA, but not causal. Do we understand that? Okay.
So smoking is.
It's not a trigger.
Okay, not
It's
trigger.
just a risk. Like it just typically tends to happen to more often to 30s and 40s women who smoke, but the smoking is not what the trigger is. The trigger is like one big thing, right? I mean, unless you sat and smoked like 7 packs in one day, maybe that could be your trigger. Yes, that is dangerous. I would not recommend. Okay.
Yeah, that is not.
All right. So signs and symptoms. Your body is under a massive attack. Yeah.
Yeah.
So how you think you're going to feel?
Tired.
Tired and crappy.
Fatigued.
You're going to feel like eating.
No.
So they'll have anorexia, which leads to
Weight loss.
weight loss. Their joints are going to start getting, oh man, I feel kind of
Nice and
stiff. Feel kind of crappy. Okay. They're just going to, and they get these like random fevers, right? Because their body's like, oh, I'm inflamed. Okay. I won't be. Okay. Then you'll see number 2 on signs and symptoms. What happens next? Then they're going to start getting the articular symptoms. What does articular mean?
Like specific.
Joint.
Joint.
Yeah. So we will see limited range of motion. They'll be stiff. Oh my God, I lost my phone. Hold on one second. Let me get my phone because I have one second. All right, back. Okay, so they're going to highlight morning stiffness. Okay, because this will help differentiate RA from lupus, because RA and lupus are very similar. So they wake up very, very stiff in the morning, can't really bend their extremities. They're very, they have limited range of motion. The joints may become painful, swollen. What is an ulnar drift?
Is that like when it's hard to rotate?
No,
Like
where's
it-
your ulna?
But like
Okay, it's this one.
This one?
Right.
Yes.
Drift, what does to drift mean?
like to
To
block.
go towards. So all of your fingers will start curving this way. Not like this, like this. I'll show you.
Oh, my mom has that.
What? She
Yeah.
have RA?
Yes.
Oh, well, that would have been helpful to start with.
Osteoarthritis, psoriatic arthritis, Dupuytren's.
Good, God almighty.
Wow.
Yeah. My hands are gonna be great.
Your genetics.
You do not have to induce your gene,
Calm down.
so just act right. Okay, this is an ulnar drift.
Ooh.
Okay. You'll see this? Did you see it?
Yeah.
All right, so that's ulnar drift. Nodules. What do nodules look like? just like
Swollen
big
little
bumps.
lumps. So where your bone gets degraded, you know, your bones will always overcompensate building new bone. So in the places where it gets worn down, it will overcompensate and then form big giant nodules. Now that's normal for people. Like if you break your arm here, you'll probably have a big lump there for several months as your body overmade the bone, and then it'll just kind of like shave it off over time. But theirs is constantly under inflammation, so the nodules just stay there. Okay. All right, swan neck deformity. What is this?
Like where the finger like goes like this.
Yeah, it's pretty bad. Let me show you just in case you don't know what it looks like. Y'all know what a swan is, I would assume.
Yeah,
It's a little what?
necks go like this.
Yeah.
And that's what the fingers are gonna do. Their necks go like this. Oh, okay. Yeah. So it's gonna look something like this. Okay.
Can you imagine what? I can't imagine grabbing something like
You
that.
can't. Yeah, you can't open jars or anything like that. It gets very, very difficult to just perform ADLs. This will lead to deformities and disability, obviously. Yeah.
Yeah.
Yeah. Yeah. What's a boutonniere deformity?
I'll show you that. I cannot tell you.
I can't remember.
I don't think I've ever seen it.
No, you gonna learn today. It's like a swan neck, but instead of going forwards, it goes backwards.
Oh, it's like
So
this. Okay, sorry. Okay, yeah, so kind of like.
yeah, goes the other way.
Okay.
but we're just gonna
Oh my
put
God,
it
Adam already has
outside.
it. Somebody help, somebody help.
My pinkies have never worked right, so
Oh, are you double jointed?
no.
It looks like it. Yes, you are.
Is that double jointed?
Yes. Do you see it when it?
I can only do these
Yeah,
though.
that's creepy.
I can't like
Something
normal.
strange genetic happened. I can't make it normal. It's never going to be normal. All right. So that is the articular signs and symptoms. But remember, RA is systemic because it is called rheumatoid arthritis. Yeah. So it's going to attack every other part of your body. No big deal. You can just get pericarditis, myocarditis, or endocarditis. All three layers can be affected. Yes, just to make sure that y'all know what that is. When you have pericarditis, what signs and symptoms quickly will you see? Quickly, which signs and symptoms would you see?
Shortness of breath.
Like
It's around the
rubbing-
heart.
Like rubbing something like
Rubbing something?
no like
Oh, it's like a
pleural
Pleural.
effusion, like sandpaper sound.
That's for
lungs.
pleuritis, not for pericarditis. Okay. What is the pericardium?
So like
The outer layer of the heart.
Is it a sac?
Yes.
Yeah.
Yes. So your body would say,
Something's wrong.
and that sac would
Fill it-
fill with
the
fluid.
Oh, so it'd be like shortness of breath.
Oh, this is around their heart, not their lungs.
Yeah, they'll be short of breath because their whole body's not getting oxygen.
Is
Well,
it like
because,
a
like-
weak pulses, like weak heart rate? or something?
Okay. It's muffled heart tones. So when
Okay.
you listen, you're not going to hear it beat very much. Now, yes, eventually you could get to the point where it would cause decreased cardiac output, and eventually you get to the point where you'd have decreased peripheral pulses and things like that. But at first, as it starts to fill with fluid, it's basically like compressing the heart, right? So when you listen, you won't hear a heart tone like beep, 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 like because it's in fluid. You understand what I'm saying?
It's
Okay.
drowning in it, it's drowning in it.
What about myocarditis? What is myocardium?
Muscle.
That's the muscle layer. So that's going to get all angry and
It's like weak. almost.
it gets inflamed.
Okay.
Well, yes, it could over time become weak, which will give you signs of like a cardiomyopathy, right? It would look like almost like heart failure symptoms because the heart muscle eventually will fail, right? All right. What about endocarditis?
So that'd be like valvular and all.
Yes, it's around the valves. So this could cause regurgitation. This could cause heart failure like symptoms too, huh?
Would it cause murmurs?
Yes, you could have a murmur.
Yeah.
Yes, you could have clicks, right? When the valves are trying to open and then they click open. Yeah.
Mhm.
Okay. Endocarditis has a very high rate of what complication? Number one complication of endocarditis.
Am I?
This is
Heart
in the
failure?
heart, not outside the heart.
Heart failure.
Infection, like a.
Where? Infection where?
Of the
Where's the endocardium?
inside.
Inside the heart. Usually we refer to it around the. You already said it.
The
The
valve.
valves. All right. What goes through your valves? All your blood. Where's that blood go?
Oh,
So
sepsis.
Sepsis. Yes.
Sepsis.
Endocarditis and sepsis are super highly related. Okay. All right. It also really likes to attack the eyes. We've sometimes diagnosed people with RA just based off eye exams. They had no other symptoms, but they had this persistent red eye. Okay. It could be one, it could be both. All right. Episcleritis, which is inflammation of the,
Oh, the
Sclera.
sclera.
okay. Conjunctivitis, which is inflammation of the conjunctiva, which is underneath here, right? Okay. Keratoconjunctivitis,
Inflammation of the skin around it.
not skin around, the keratin across the eye, right? So all three of those can lead to eye redness though, right?
Yeah.
Right. And so if we think, oh yeah, maybe it's pink eye, and then they treat them with antibacterial drops, it didn't go away and it just keeps flaring up here and there. And then they start complaining, like, I'm also really tired and I can't read, and then we're like, oh no. Okay. All right. It also likes to attack the lungs. Okay. Big time. So you will see interstitial fibrosis. What is fibrosis?
Scar tissue.
Which is a hardening of the lungs. When they try to take a deep breath, it just stops there, right? Which can cause shortness of breath and pneumonia, right? Pleuritis. This is the one you like, Caitlin. What is pleuritis?
It's like where the sac, like where the plurals, like the sac that surrounds like the lungs fills with fluid.
And it's angry, right? So when they take a deep breath, what will you hear? Just said it earlier.
Like rubbing.
The sandpaper sound, right? You're going to hear this called a friction rub. Good job. And when they take a deep breath,
Pain.
it hurts. Yeah. And they can also get nodules in the lungs. That's bad, y'all.
Wow.
Nice.
Yeah, just bumpy lungs that don't open. Yeah. All right. Then we will also see peripheral neuropathy, so they can get inflammation around the nerves, right? What is vasculitis?
Inflammation of the
Vessels.
All of your vessels, which tells your body
Something's wrong.
and brings a bunch of platelets. Oh no.
Uh-oh.
So they're going to be at risk of
MI.
all kinds of
Sure.
clots, right? Clots everywhere. Yeah. And they will also have at the bottom, in case you can't see it, is anemia. Okay. Why would patients with RA get anemia?
Because like
Yes, because.
Maybe because they have that vasculitis, so there's a lot of platelets now, and then also because they're having inflammation all the time.
All right. So if they have a chronic inflammatory response, their body's metabolic needs are much higher. So they're going to use oxygen much more quickly. Almost every patient that has a chronic disease gets an anemia, including cancers, autoimmune disorders, because your body's in such a high metabolic state that it eats up that oxygen very quickly. Do you understand? Okay. On top of all that, you're also going to have lymphadenopathy. How come?
Your whole body thinks that you're under attack.
Yeah. So the lymph
system.
system is going to be like, I got you, but you're going to have like big swollen lymph nodes. You're going to have splenomegaly. What is splenomegaly?
Large
big
spleen.
spleen.
Large spleen. What's the spleen's job?
Make
Like
red blood
cycles.
cells.
It does help to make red blood cells. It's also the graveyard of the red blood cells, which obviously you're gonna have a lot of red blood cells going to the spleen, and the spleen has a huge immune properties as well. So it's being overworked in all three ways, right? So you will have splenomegaly. And then there's a lot of syndromes that are associated with RA. So you don't have to have these syndromes to diagnose RA, but like if you have RA, you likely have at least one of these other syndromes. Are we ready?
Yeah.
All right. Y'all will probably need some Post-its for this one. All right. What is, because I probably don't remember these. I think I covered, oh, y'all weren't here. Okay. Felty syndrome. Felty's, I'm going to tell you what these are because y'all won't know these, right? Okay.
No.
So Felty syndrome, we diagnose someone with that when they already have RA, but they also have splenomegaly plus leukopenia. What's leukopenia?
Low white blood.
Low white blood cells, because basically they're being overworked all the time, right? Patients with RA typically would have high white blood cell, right? Because it's an inflammatory response. But in Felty syndrome, their white blood cells are being pumped out so rapidly and so quickly they get depleted. And then the fourth criteria is frequent infections, which would make sense because they have no white blood cells. Okay, so the four things that we have for Felty syndrome are RA, splenomegaly, leukopenia, and frequent infections. Okay. So I mean, it basically kind of makes sense because you have this chronic inflammatory response and now your white blood cells are all like, and your spleen's like, I'm done. And so you're getting infected all the time. Do we understand?
Yeah.
All right. That's Felty syndrome. Kaplan syndrome, that's when you have RA plus lung inflammation plus lung scarring. Okay. RA plus lung inflammation
And lung
and lung scarring. So these are the patients that have RA, but they have many more like lung symptoms. Not everybody with RA has the lung symptoms, but if that's predominant with them in RA, then we will also diagnose Kaplan syndrome. Okay. Okay.
Okay.
Okay.
What else is on here? Sjogren syndrome. All right. So Sjogren syndrome, you can use the keyword anticholinergic. Everything dries out. So they get dry eyes and dry mouth and constipation, urinary retention. Everything is super dry. And you're going to treat it just like we did with all, medication that's an anticholinergic, right? Like artificial tears and hard candies.
Saliva.
Yes, artificial saliva, fluid fiber mobility, all the same stuff that we normally would do. Raynaud's, y'all should know Raynaud's phenomenon.
Right.
All right, what is it? It is a peripheral
Vasoconstriction.
vasospasm, right? And that happens because there is some kind of trigger, usually
Cold.
cold, and then they get this peripheral vasospasm. What do we call Raynaud's? We had a keyword for it. It's colors.
Red.
The red, white, and blue disease, right? Because at first, America. Because at first, their fingers will turn
Red.
white, correct. And then because they don't get blood flow. And then as the blood flow continues to you don't got any, then it turns blue. That is correct. And then as the vessels open and the blood rushes back down there, then it will turn red. Okay, so it's red, white, and blue because that's just how we say it, but not in that order. Because nobody says what are the colors of America? White, blue, and red. You don't say that. All right. Carpal tunnel syndrome. You know what carpal tunnel syndrome is?
Yes.
Okay, well, tell me about it.
So it's an inflammation of the medial nerve.
Yes, it is a problem with the medial nerve, becomes very inflamed. And so these are usually people we see that have problems when they type and things like that. And there's a lot of pain. But that often comes with RA as well. Are you with me?
So it's an inflammation of the nerves.
Yes, but just this one in the hand. Medial nerve. Medial nerve. Medial. Anyway. All right. Do you understand signs and symptoms of RA?
Yes.
Let's diagnose it, shall we? I'm doing good. I ain't even mad at you. All right. For the most part. So if a person comes in and says, hey, I feel super tired and crummy all the time, and I'm getting sick all the time, and I just don't feel well. That could be anything, right? That could be lymphoma, leukemia, RA, lupus. I mean, there's a million different things. We're going to start with the basics, right? What'd you say?
I was jokingly saying cancer. I mean,
No, it could, absolutely. HIV, right? There's a million different things. So I need to just get kind of TB, sure. So I need to get let me get a feel for this. So I start with the CBC. What would I see on the CBC?
Anemia, maybe?
So
Maybe. So I might see the H and HB low, but I would definitely see a high white blood cell count, right? Because this is a inflammatory response. If they're in an exacerbation, it's usually over 20,000 when I see them. But the problem is it takes 3 months to get into a rheumatologist, and there's no guarantee when you get in that you're going to be in exacerbation. So your labs may be completely normal. So RA can be very difficult to diagnose because unless we see you in active exacerbation, you may not have lab changes. Okay. What are the markers of inflammation? ESR and CRP. The ESR is what is it actually? The name of it? Erythrocyte sedimentation rate. Sometimes you may hear it referred to as a sed rate. Okay. And then the CRP.
Chronic rheumatic
Stop it.
problem.
I'm not even going to repeat that. I'm just going to.
Is it something reactive protein?
Yes. C-reactive protein.
C-reactive.
Yeah. You got the hard part. A C-reactive protein. Those are going to be elevated because your patient's in a massive inflammatory response. So if I see those in the CBC and the ESR and CRP, I'm I need to do some more digging. This could be RA. So I'm going to draw an RF. What's an RF?
Rheumatoid factor.
It's a rheumatoid factor. If it is positive, that 100% is RA and you can stop the diagnostics there. But there are 20% of people who test negative for RF, but still have RA. You will also notice during this module, I will say nothing but a bunch of letters put together and you will know what I'm talking about because you're smart. Yes.
Hurts my brain.
I know you got to really think about it, man. You got it. Okay. So, because basically what it says, so what you're going to do is CBC, they're going to have high WBCs with a low H and H, ESR and CRP are elevated, RF positive. You see, I'm just saying a bunch of, yeah. All right. But if their RF is negative, but I still think they have RA, then I'm going to do some more digging. Okay. I can do an ANA. What is an ANA?
It's
like
What does it stand for?
autoimmune.
Let's start with the stands for first, and then we'll go to that. And ANA stands for,
Is it that hard?
I don't think it's hard.
That's you.
Oh,
for me.
it doesn't have crazy words in it, if that's what you're
Okay.
saying.
I want to say the N's for neutrophil.
It is not.
No.
I know there's antibody at the end.
Yes, antibodies at the end. Okay, so we're 1/3 of the way there.
Active.
Anti-nuclear
Oh my gosh.
Anti-neutrophil.
antibody. Anti-nuclear antibody. Okay, that's an ANA. If an ANA is positive, what does that tell you?
Oh, there's an autoimmune.
There is an autoimmune disorder. Does it tell me which one?
No.
No, so now I still got to dig. So if the ANA is positive, I'm like, okay, I know they have an autoimmune disorder. I just need to make sure that it really is RA and I'm not mistaking it for something else, because RA and lupus, like I said, very similar in how they present. Okay. So I can also draw what's called an anti-CCP. That is specific to RA only. It's like a citrulinated peptide, I believe that's what it's called. Hold on, let me look it up.
Cool. We're not being asked.
I know this one I have a hard time remembering for some reason. Yeah, citrulinated protein antibody. Anti-citrulinated protein antibody. Okay. That's why we call it an anti-CCP. Okay. All right. Anyhow, so if that is positive, that is specific to RA. So if that's positive, then I would say you have RA and I'm done. If that is negative, but I'm still like, I really feel like they have RA, I can still diagnose. Okay. And we can do some imaging studies to see if there's some changes in the joints. So in an X-ray, X-rays are not real great imaging. You know that, right?
Right.
So you may see like a narrow joint space, like we should have spaces between the joints, right? But as it gets inflamed and as we start to destroy the joint, that'll get smaller and smaller. Yeah.
Yeah.
Okay. We may also see less cartilage because the cartilage is already being destroyed, or we can see malalignment of the joints, but basically it's just giving us an overall view. It doesn't show very clearly. Where'd you go?
Oh.
Okay.
Yeah, I'm listening.
Yeah, All right. So then we can also, if we want something more detailed, we can do a bone scan because that'll give us a little more detail on the bone. We can see a little better. Or we can do a synovial fluid analysis. Now, how would I do that?
Do they stick like a needle?
They stick a needle in your joints,
Aspirate
the
aspirate the fluid, and then they send it to the lab and test it.
And they
And
drink it.
They definitely don't do that. That is a vampire movie or something. So strawberry colored fluid is what you'll see. Why is it kind of a pinkish red?
It's like the blood.
What?
products.
It's inflammation.
It's inflammation because your whole body or the joints are like, something is wrong. And there's so much pressure that as it leaks fluid into the third space, edema is usually clear, right? Like if you pulled edema out, right? It's clear fluid, but because it's got so much vascularity to it, when it pushes that fluid out of the vessel, some of the blood comes along with it. Okay. You may also see what's called fibrin flex. What is fibrin?
It's the stuff that holds the clot together.
All right. And what tells your body to make fibrin? Because it helps with clots, right? Huh?
Factor
10.
10 does help, but I mean, just overall step back just a little bit. I'm proud of you for knowing that though. Just factor 10. Yes.
Prostaglandin? No.
No, it's pain.
Yeah.
Is it like a specific?
No, I'm just looking for a very generic, like what tells your body to make like clotting factors and fibrin and like, what's the signal?
You cut yourself.
Fibrin?
Right. Something is wrong. So when your body knows something is wrong, right, then it's like, okay, I don't know what that something wrong is. So I'm going to send everything out there, right? I'm going to send platelets and clotting factors and heparin and histamine. It sends all those chemical mediators. You may see fibrin flex in there, meaning like your body knows there's a lot of blood flow there. And it's like, let me try to clot it, but it's obviously not going to be able to because there's so much fluid in there. In the synovial fluid, you will see a white blood cell count greater than 25,000 actually in the fluid.
Whether they're
Dang.
in exacerbation or not.
Well, no, they'd have to be an exacerbation. Otherwise you wouldn't have a lot of synovial fluid to pull,
Okay.
right? So you'd have to wait for them to be an exacerbation. If we do all of that, and I still didn't see any evidence of RA, but in my heart of hearts, I know they have RA. I can do a clinical diagnosis. Okay.
Oh, okay.
You would have to meet 4 different criteria. Number 1, the disease process has to be polyarticular, which poly means
Many.
articular.
joint.
So many joints have to be affected. They can't just say like, oh, my elbow hurts, right? It has to be elbows and knees and like multiple joints. So, you would have to look at the serology and something would have to show you that there's like some kind of likelihood, either an RF or an anti-CCP or something in there. Yeah, something in there has to show you like something has to pop. And then number 3 would be acute phase reactants. Those are our ESR and CRP. And the duration of symptoms has to last greater than 6 weeks. Okay, there's a scoring system that they use for the clinical diagnosis. You do not need to know how to score because it's very detailed. But what you do need to know is if they score greater than 6, we can still diagnose them clinically with RA. Do we understand?
Yes.
All right. So treatment. Look at me, not your papers. What is the first treatment for RA?
NSAIDs.
NSAIDs when?
Every day.
Daily. What happens in exacerbations?
Corticosteroids.
Corticosteroids during exacerbations. If they have frequent exacerbations, then we do immunosuppressants. What's the immunosuppression of choice? Methotrexate. Now, DMARDs, I've heard y'all mention that several times. That's a fake drug class that somebody created. There's no actual drug class called DMARDs. What does DMARD stand for?
Disease
Modifying
rheumatic-
rheumatic drugs. So basically it's an umbrella term for saying these are the drugs that we use to treat RA. It's not a drug class, right? Because underneath DMARDs would be NSAIDs, would be immunosuppressants, would be methotrexates, would be corticosteroids. You see what I mean?
Yeah.
Okay. Would also be TNF inhibitors. Do you remember learning those in pharm?
Fibrosis factor.
Yeah. What do they end in?
Mab?
MAB. I told you, anytime you see a MAB, what's the first thing you need to pick on an exam?
TNF. Or,
Well, yes, but what do you like do for that patient, or what do you have to make sure? Infection risk. So do not start them if they have any type of infection, right?
or sore throat and fever.
Yeah, huh,
Sure.
or anything,
Yeah.
any signs and symptoms. So we set our goal is to prevent joint destruction, and we do that by treating them with these medications. Okay.
Okay.
All right. The drug of choice for adults is methotrexate for the immunosuppressants. Okay. Or the number one, if they ask what's the number one DMARD, you would consider that methotrexate. Okay. But they usually will start with daily NSAIDs. Do you understand?
Yes.
So that's why it says on here, daily NSAIDs plus corticosteroids and exacerbations plus or minus a DMARD within 3 months of diagnosis. So if you're going to need to start a DMARD, you really should start it at the beginning of treatment within the first 3 months. Does that make sense? Okay. Do y'all remember sulfasalazine?
Wait, what?
I don't like
Oh,
salad.
isn't that the mix?
Sulfasalazine.
It's
We
like
learned
mixed
this
with
in,
aspirin-
yes,
Aspirin and the sulfa.
aspirin and sulfa drugs. We did
Yeah.
this in the GI module because it's also used to treat
Beauty?
Rheumatoid arthritis.
in the GI module. We learned this in the GI module.
Peptic ulcer disease.
Okay,
said
y'all,
that.
I cannot
said
help
that.
you.
Um,
Sulfasalazine obviously
Hold on.
treats autoimmune
Uh,
disorders, and we learned it in the
Crohn's.
GI module.
oh.
Crohn's?
Crohn's,
IBD.
right,
Okay.
inflammatory
where
bowel
is-
disease.
Wait, is that on the paper here? Where is it? Oh,
What?
sulfasalazine.
Yes. Help me, help me. Okay.
I'm blind.
So sulfasalazine, y'all remember it had aspirin, it had sulfa. Was a number one big thing to know about sulfasalazine? Allergic reactions, sister, get it. Hypersensitivity reactions was a big one. If you're allergic to sulfa or aspirin, probably ought not take it, right? Yeah. And then they use the anti-malarial drug HCQ, which is hydroxychloroquine. Excellent drug, been around for a very long time, works beautifully. Okay, very few side effects. And then we can also choose an immunosuppressant, but remember those like really suppress your immune system. So you have to worry about infections. And then when they get an infection, they go into an exacerbation. So you're kind of like, does this even make sense? Right. And that was azathiopurine or cyclophosphamide. I think we already covered cyclophosphamide.
Chemo drugs.
Yeah.
Oh yeah, it was.
Yeah.
We did have it in chemo too. You're right.
Um,
Yes.
I know, I had to think about it for a second. I was like, wait, was it in that module? Yeah, it was. Okay. Because some of the modules, you know, overlap, like methotrexate overlapped. Sorry, I know, sorry. All right. And then we have what we call our biologic drugs. These end in MAB or SEPT. These are TNF inhibitors. I told you, big clue.
Infection.
Never start them if they have any signs of infection, especially TB, and they have to have a PPD before treatment. Do you remember that?
yeah.
Okay. All right. Now we're going to get into the nursing care. Are we ready?
What about the surgery?
Oh, yeah. So if their joints become completely destroyed, then we may have to go in and do surgery. Sometimes they'll shave off part of the bone. Sometimes they'll have to reconstruct the joint because eventually these patients are going to get to where they're bone on bone. When you rub bone on bone, your body's going to overcorrect that bone so they can get bones first too, right? So they may have to have surgery for those kind of things, but there's no surgery to obviously fix rheumatoid arthritis, right? It's just to kind of help you with the symptoms.
I would know. My mom got like 4 surgeries, but I just wanted to.
Dang, really?
Yeah.
What'd she get surgery on?
Huh?
What'd she get surgery on? Her joints?
Yeah, on both of her hands.
To correct the deformities?
Yes.
Yes. Very painful.
Never worked. Let's
Oh,
go.
well, That's a bad doctor. Okay. So nutrition. All right. Remember they have anorexia and weight loss. Okay. But what happens is at the beginning, they're going to have anorexia and weight loss. As they become less and less mobile, they typically tend to gain weight. We don't want any excess weight on this patient because that's going to put even more pressure on the joints, right? Okay. So we're going to do small, frequent meals. There is no RA diets. We just say have a healthy diet, obviously fruits, vegetables, stay away from processed foods, sugar,
Would it not
dairy,
be
gluten.
heart healthy because of the 3 different itises that can cause pericarditis, myocarditis?
No, because those are all happening to the heart structure, not necessarily to the heart vessels.
Okay.
You see what I mean?
In the diet would also, it would kind of depend on like what they're taking, right? So if they're taking a MAB or something, you could be like, no fresh fruits.
Oh, I see. Yeah. If they're taking a MAB and they're on neutropenic precautions or they're on immunosuppressants, they'd be on
Then it's like
neutropenic
the- yeah,
precautions.
the-
Right. But for a patient at the beginning of RA, we just say, hey, have a healthy diet, lots of fruits, vegetables, good healthy fats. You know what the healthy diet is. We do tell them to increase protein a little bit because it does help with fatigue, right? Because it helps to sustain your blood sugar levels over time. And then we want them to do a daily weight because I need to see
Fluid
how much fluid they're retaining, and also want to make sure that their BMI stays less than 25 so we don't put extra pressure on the joints. Yeah.
Yeah.
Yeah. All right. Meds that they're taking, you do have to do a lot of teaching because most of these that we talked about are kidney and or liver toxic. So you should know what to do for those. Yeah.
Mhm.
Okay. So we watch their LFTs, B1, creatinine, GFR, and report any signs of infection if they're on immunosuppressants, if they're on sulfasalazine, if they're on TNF inhibitors, if they're on methotrexate, right?
Yeah.
Even
Yeah.
corticosteroids if they're taking them for a longer period of time than just a couple days. Yeah.
Yep.
Okay. Pain management. So alternating heat and cold is helpful because the heat helps with the
Pain?
stiffness and the cold helps with the inflammation because heat dilates and cold
Correct.
right. So 20 minutes max of each, and make sure you put some type of something in between you and that heat source or that cold source, right? Like we don't want to put like ice directly onto their joints, right? You want a washcloth or something like that underneath. When they take their daily NSAIDs, okay, NSAIDs are toxic to the
Stomach.
yes, and the stomach and the kidneys. Okay, so you always want them to eat before their NSAIDs, but they're supposed to take NSAIDs first thing in the morning. So we'll talk about their morning routine in just a minute. Warm baths are very helpful since this is a systemic thing, like as warm as they can tolerate to help loosen up their joints is really helpful, especially in the morning time. And they're going to need to allow themselves extra time in the morning to wake up and get ready for work because this is going to take their morning routine takes a long time.
Because that's when it hurts the most, when they haven't moved in a while.
Yes, when they haven't moved all night, they wake up, they're very stiff. It's very, very difficult to move and get out of bed.
Morning stiffness.
Yes. Sounds weird, but yes,
Doesn't
morning
mean that
stiffness.
little
Yeah.
bit.
Yeah. Sounds like something worse. Okay.
Yeah.
So usually what they'll say for them to do in the morning is to set an alarm clock. Okay. Then they're going to wake up. There should be a small snack at the bedside. They're going to eat a little snack like a granola bar or something, pop their NSAIDs, go back to bed for about 30 minutes to an hour. I can't do that because once I'm awake, but this is ideal. Okay. Then once they are awoken after the 30 minutes to an hour, the NSAID should have kicked in by then. At that point, they are to go and get in a warm bath to help to loosen up those joints. That'll help with the stiffness, right? Then after that, when they get out of bed, get out of the bath, then they'll apply cold to the different joints that are very swollen and causing them problems, okay? Then they need to eat a full breakfast because they're going to be taking other meds throughout the day, right? I mean, this process takes a good amount of time. Yeah, it takes a good amount of time.
What'd you say after the warm bath?
Warm bath, get up and eat a good breakfast,
Okay.
right? Because we want to make sure
I
we're
thought it was like
maintaining
a
their weight.
cold
Oh, yes,
pack.
cold packs too. Yes, well, cold packs if they need to, and they can do the portable cold packs too, because you can't just sit there with a cold pack, you know what I mean? The ones that they just wrap around.
Yeah.
And they have a little ace bandage thing that kind of wraps around. So you can still get on with your day. Oh my God, why are you talking to me? Okay, so move their joints Q1 hour. Now clue into this on the exam because usually we say turn Q2, but for them, if they sit still for 2 hours at a time, they're going to already be stiff, right? So we want to move their joints every hour. That doesn't mean they even have to get up. They just have to move the joints, I mean, they can't get up. That would be helpful, but they don't have to. Highlight splint use overnight. Because I used to think like, what the heck? This doesn't make any sense. Splints, I would think like would make it worse, but they keep everything in alignment while they sleep. So when they wake up, they can actually like move their joints better because, like when you sleep, your hand gets all tucked underneath you or whatever. So they're going to keep things in alignment. Heat for the stiffness, ice for the swelling. We talked about that. Non-weight bearing exercise because they're not going to be able to do a lot of weight bearing. That's going to hurt the joints. So we always pick swimming. What's the only exception to picking swimming in all of nursing school? What disease process?
Oh,
Hypersomnia?
No, what the
I know for seizures and epilepsy, you can't go swimming.
Well, that's true, but there's only one disease process where you will not pick swimming in all of nursing school. You want weight bearing in that disease.
Oh, osteoporosis.
What the hell? How did I just one tiny little change and you twins just pop right up? All right. Osteoporosis is the only one that we would want weight bearing, but we don't want weight bearing for them. Swimming is good because it helps them with resistance, but it doesn't put any pressure on the joints. They need to be in physical therapy, occupational therapy, make sure they take pain meds before exercise or they're not going to be able to do that. Right. Lie prone for 2 hours daily. Why? That's so weird.
Frankly, I don't get it either.
Like the front, like they're laying on their face.
Yes. Well, their head can be kind of turned to the side.
Does it have something like it can help them like coughs? Something so?
Oh, I know what you're talking about. Sometimes we do prone patients to help with respiratory, but that's not, well, actually that is kind of, okay, let me
Is it the
go with
lung-
that, go with
is it
that.
The lung thing, the lung issue.
Yes, it can help with the
Okay.
lung issues because you'll know when patients are having really bad lung issues like ARDS, acute respiratory distress, or
Yeah.
the patients that were like in ICU for COVID, we proned them because it helps to open up the lungs, right? So I do agree with that. That is one of the reasons why. It also helps with body alignment because when you're laying flat, your hips are usually in a kind of a backwards position, but when you're laying prone, it kind of forces your hips up a little bit. So it can help with body alignment. And it doesn't have to be 2 hours all at once. Like nobody wants to lay on their belly for 2 hours, right? Like that's insane.
Yeah, that's a good
I'm
thing.
going in, see y'all in 2 hours, like, you know. No, no pillow under the knees. Why do we not want to put pillow under the knees?
Like a clot risk?
Class, that's a DVT risk, right? Use a high seat chair and armrest, and you can do this on the toilet as well, right? So that way they have less that they have to like stand up from, right? Because this chair is like relatively short. And so if I had RA and I could probably sit down, but now that I'm down here, it's going to take me a lot more to get up. Right. So they want to have a seat that's elevated. So that way I only have to sit down like this and the armrests are up here. So it's easier for me to push up. I don't have very far to go.
Is that kind of like with MS also?
Yeah. Cause it's the same mobility
Yeah.
issue. Yes, absolutely. MS would be the same. All right. Slide, don't lift. You should already know that. That's a concept for everyone. If you're having to move something, slide it, don't lift it.
Right. From
Patients.
Right, with patients.
Yes, slide, don't lift. Okay. We may have to do Velcro and zippers instead of buttons because those things might be a little bit too difficult. Even tying shoes can be really hard. So Velcro shoes are actually like all the rage with RA. This also happens with ADHD kids too. Do you know that they can't tie their shoes
Oh,
Really?
or it takes them a really long time to do so.
So long as a kid.
Yeah.
I was like,
Caden was 10 when he learned to tie his shoes and it was such a battle. Do you have ADHD?
I think I do, but they
Oh.
said I don't.
Who said it? Who's they?
It's like a psychiatrist.
Oh,
I
they're
do.
stupid. Okay.
It's like
But anyhow, at some point you just I kept struggling with him and he would just cry and he couldn't figure it out. And so the OT that we talked to was like, forget it. Like, who cares? Just get him Velcro shoes. Or I get
Where's
the
the
ones that
bun?
actually I have these. These aren't actual ties. They're just fake. Yeah, so you don't have to tie them at all. So we'll do different acclimation things just to help, you know. We do want them on an exercise program, right? Because we don't want them to have massive weight gain. Range of motion exercises should have been a given. Yeah. All right. For the fatigue, frequent rest periods is a given. We do have them talk to their employers about either coming in late because their morning routine takes a long time, right? And just say, hey, can I start my work day at 10? Okay. Yeah, this would not work for a nurse. Okay. Yeah, they're never gonna let you do that. Or ask for a shorter work day. Like, hey, can I work from 9 to 3 instead of 9 to 5 and finding a job that has a shorter hours. So you're not as fatigued by the end of the day. And naps are encouraged. I feel like naps are a huge testing point in nursing school. Some conditions you can take naps and some you can't. Like narcolepsy, take naps or not.
No.
Yes, we do because
Oh, they'll fall asleep.
they'll fall asleep anyway.
Yeah.
Okay. Alzheimer's, take naps or not.
No.
No, because they have nighttime wandering. We
Insomnia.
want them to sleep at
Yeah.
night. So there's always big things about naps. We want them to take naps because they're going to be very tired. Okay. All right. Psychosocial, refer to a support group, and it is very important to discuss their sexual needs because you can't really bend that way. Yeah. So that we usually will refer them to somebody to talk about their sexual health and different things that they can do other than,
Starfish.
oh my God, I am dead. I am
I'm
dead.
Just
That is an option. I won't even tell you what he said. Oh, I will not. So anyhow, there's lots of different things that you can do. And there's other like sexual things you can do other than just intercourse. They're going to work with that patient on that. Oh my God, that was the funniest thing I think you've ever said in your whole entire life. Okay. Goals for this patient. Number 1, prevent joint destruction. We want to get pain relief. Okay. Usually we can do that through NSAIDs. We do not use opioids. So how come?
Because they can take too much, right?
And this is a long-term degenerative chronic disease and they will get addicted. Yes, dependence, tolerance, addiction. So we do not use opioids. Perform self-care. So we want them to be able to do their own things on an exam. If they ever say like, hey, the patient's having a hard time washing their hair, brushing their hair, whatever, what are you going to do? You don't do it for them. You'll usually get occupational therapy or you work with them to help them figure out a way to do that because you're not going to be there with them when they go home, right? They need to achieve independence. And then maintain mobility for as long as you can because y'all know once patients lose mobility, it's a downhill slide from there as far as depression and psychological things, right? All right, do we understand RA?
Oh, can you go over the-
Question.
So many questions. I don't know. No, I
Okay.
haven't. Do I need to end it first?
No.
Oh.
So for one, I wanted to say narcolepsy is the condition I was thinking of earlier for no swimming because they'll drown.
Oh, narcolepsy, no swimming. Okay, that's fair. Yes,
And,
narcoleptic should not swim.
Shoot.
Yeah.
He wants to clarify that on the video. He's like, please keep recording so that they know that that's what I was
It's
talking
not me.
about.
It's not
Shoot,
me,
I
guys.
forgot
It's not
to-
me, it's you. Okay.
Oh yeah, pain relief. No
Yes.
morphine because
No
it's also
opioids,
a
period.
Dilator, right?
Yeah, but it's a vasodilator just for the heart, which that wouldn't be a bad idea for our RA patients.
Okay, it's just more the addiction. Got it. Makes sense.
Yes. You had a question?
Oh, can you go over the morning routine again?
Sure. All right. So they will set an alarm, wake up in the morning feeling like, just kidding. So then they wake up just barely and they should have a kind of a snack at the bedside. I should have paused the recording. Okay. I'm not a rapper, Audie. Anyhow, so they'll have like a little snack and take their NSAIDs and go back to bed. That way their NSAIDs have a time to work and we also don't destroy their stomach, right?
Right.
Then they're going to get up after about 30 minutes to an hour, go get in a warm bath, soak in the warm bath. And then after they get out, they can apply ice packs if needed to joints that are swollen.
Okay.
And then they need to go eat a good high protein breakfast to get them through the day. And then start the getting dressed and those kind of things. So that's why sometimes they'll need to get a job where their boss will allow them to come in late. Otherwise, you're going to be waking up very early to do all of these things. Yeah.
Yes.
Yeah.
Any other questions on RA? We think we got it.
Yeah.
Yeah.
Cool.